Well, a special welcome to everyone. Thanks for tuning in today. This is Lauren, and we just want to thank Phil for all of his good work in putting this program together today, and a special welcome to Dr. Ron Strauss for being with us. We had a good response to this when we originally thought about it, and Phil had sent out a preview of what we're going to be discussing and the like, but a special thanks to Dr. Ron Strauss for being with us tonight. Just by way of background, Dr. Ron is a professor of clinical medicine at UCSF.
Used to be.
I'm sorry, that's right. His background includes graduating from Princeton and Stanford. He did his residency at UCSF and has worked extensively in community medicine as well as the Veterans Administration in the state of California. So we want to give you a special thanks, Ron, for being with us today. And I'll ask everyone to keep their system on mute if you can, because every time one talks, their pictures come up. And you can use the chat notes at the bottom of your screen if you have any other questions. We ask for questions to come in advance. We have a lot of them. So Dr. Phil or Dr. Ron, I'd like to turn this over to you at this point. And we really thank you for being with us.
Oh, you're welcome. I'm happy to be here. So great. Yeah. So I have a few slides I was going to share with you that I thought you might find interesting. And then I'm happy to run through any questions anyone has at the end. I think the slideshow will be relatively short, but hopefully you'll find it informative, and I'm happy to forward the slides if anybody's interested in the data in them. Okay, so how to live to be 100, no guarantees. Let's see. So first, some disclosures. I have no conflicts of interest to declare, except that my two oldest children attend Redwood High School, which some might misconstrue as a rival of San Rafael High School. And the other is Phil Strauss looks very good, but he's actually in his 70s. Okay. And then I think, as you would likely understand, the medical information presented today should not be viewed as a recommendation specific to you. As always, please discuss with your own doctor before making any changes. So I think the first question is, well, how long are you going to live? And there's some data on that, which I'll share here with you. This is from the CDC, and you can see that the life expectancy at birth in 2019 and 2020. 2019 is in the darker blue purple bar on top, and the 2020 data is in the sort of lavender bar below it. And I think that the takeaway message here, as you've likely heard, is that the shocker here is that US life expectancy actually dipped for the first time in 2020. And the reason for that, you can see that it dipped both in men and women. It was in 2019 for women, it was 81.4. For men, it was 76.3. And in 2020, it was 79.9 and 74.2 respectively at birth. The change there is, of course, a couple of things. It was the opioid overdose as well as COVID. So, okay, moving right along. This is a table. I'll hone in on part of it, but this is also data from the CDC, and it looks at age and gender and divides people into different ethnic backgrounds, all origins on the left, Hispanic, non-Hispanic white, and non-Hispanic black, and looks at how long you're likely to live based at whatever age you are at this point. And so I'll hone into the area of greatest interest for you, which is here towards the lower part of that table. So if we look at sort of all ethnic backgrounds on the left here, you'll see that at the age of 80, which many may be bumping up against, that people who've made it this far are, well, survivors. So that's a great thing and already says something very positive about what you've been doing all along. But you'll see the average person in the United States who lives to age 80 will live 9.3 more years. And that would be 8.6 for men and 9.7 for women. So that's something short of 100. So let's talk about what we might be able to do to increase those odds. Well, first, actually, before that, we can look at, what do people die from? That's always helpful to know if you want to think about what you're going to do to try to prevent someone from dying. And the leading cause of death in the United States has been for a very long time heart disease in both men and women, as you can see. The second leading cause of death in the US is cancer. It's been that way a long time. There's a newcomer in 2020, COVID-19, of course, didn't exist in the United States in 2019, at least not in any numbers we were aware of. But unfortunately, it became the number 3 cause of death in 2020. You can see below that unintentional injuries, which include auto wrecks, basically. It includes falls. And actually in this category is included drug overdose. Accidental drug overdose is included in this category, which unfortunately, as everyone knows from the opioid epidemic, has been a very serious problem in the US. You'll see that stroke, which a few years ago was number 3, is now number 5. And then essentially pneumonia, Alzheimer's disease, complications of diabetes, influenza, and other pneumonias. Chronic lower respiratory diseases would be COPD, essentially emphysema and chronic bronchitis. You see the pneumonia and then chronic kidney disease below that. So that's what we're trying to combat here. All right, so what can we do to improve our odds? I have some ideas. I think if there were one thing you could take away, it would be exercise. This study that I'm going to share with you, it was not done in people who are 79 or 80 years old. It was done in a younger population. But my guess is for many of you, it's part of the reason why you are 79 or 80 years old. The trends are impressive. And so I would certainly encourage you to continue to do all the exercise that you do. This was a huge study of about 250,000 men and women. It was done by the NIH and the AARP, actually, in looking at a population between age 50 and 71. And they basically did a couple of baseline health surveys, including activity level, and then they followed people and looked at mortality records over many years. And this is what they found. This table here shows all-cause mortality, and there's a lot of numbers on this table, so let me orient you toward it. But this is death from any cause, And so I don't know if you can see my cursor here. I'm sort of swirling it around to try to orient you a little bit to this potentially sort of overwhelming table here. But on the left column here looks at people who are inactive. And then as we go progressively to the right, we're looking at progressively greater levels of activity. And the first swath up here is people who do moderate intensity activity, which would basically be sort of the level of brisk walking. And you can think about many other things, but it's the idea of being able to exercise and have a conversation with someone, maybe not in a completely relaxed at-rest conversation, but to be able to converse with somebody in some degree of a sentence at a time. And if you look at people who, I have my cursor here over less than 1 hour a week of activity. The next category is 1 to 3 hours. The next is 4 to 7 hours. And the final column out here is greater than 7 hours of moderate activity. So this would be like an hour a day of brisk walking would be, get you out sort of towards the end here. And you'll see that it is a highly statistically significant trend that even people who do less than 1 hour per week with sort of a full adjustment for age and sex and smoking status and weight actually still have a 15% reduction in risk of dying. This less than 1 hour per week of moderate walking compared to somebody who doesn't do any exercise at all. 15% with a 1 hour, a 45-minute walk per week. Impressive. And if you look out to 1 to 3 hours, you see a 21% reduction, 4 to 7, 24% reduction, and more than 7 hours, more than an hour a day of kind of brisk walking level. And you can think about, equivalents on an exercise cycle, or there's many ways that one could think about this. But you see a 32% reduction, essentially a third reduction in your chance of dying from any cause. Wow. And part of the wash into this trial was to actually give time to people who were already sick with heart disease or cancer or something like that, essentially to allow them to pass from something pre-existing so that they felt that everybody essentially started at a similar baseline. And if you look at people who were doing vigorous activity, which would be, sort of jogging level or above type stuff, you'll see the same trend and even slightly more impressive mortality reduction. And this is true for mortality from cardiovascular disease. People who do brisk walking for, at even less than 1 hour, less than 1 hour per week, it didn't help you. But let's see, you had to get between 1 and 3 hours here. You had a 20% reduction. And for people who are doing about an hour a day or even a little more, 35% reduction in cardiovascular disease. And if we look at even mortality from cancer, which I think a lot of people know that exercise is good for your heart, but it also reduces your risk of dying from cancer. People who are, doing brisk walking for 1 to 3 hours per week total. This is total for the whole week, 30 minutes, 2, 3, 4 days a week, have a 14% lower risk of dying from cancer. And if you're doing it more than that, up to 17% lower risk of dying from cancer. So pretty impressive. Now, what does it make sense to do when you're 79 years old? Well, whatever you're doing, keep doing it. If you're exercising and you feel good about it. If you're not exercising, you want to do a little more, I think it's probably a good time to reach out, connect with your doctor, and think about what might work for you. But that is one of the most important interventions that we have, and it's free. So what else you can do is be vaccinated, and not just against COVID. This is data here from Omicron and New York City. And you can see that people who were vaccinated were about 10%, 90% less likely to die from COVID-19 than people who were not fully vaccinated. So if you are incomplete in your vaccination, or you haven't had a booster COVID vaccine, I would highly recommend that you go and avail yourself. Also free. Don't smoke. Smoking is the leading cause of preventable death in the United States. There are about 500,000 deaths per year in the United States. And in fact, smoking is responsible for about 1 in 5 deaths in the United States. So on average, smokers die about 10 years earlier than non-smokers. So it costs people a decade of life. And probably many of you are not smokers, or you might not have made it this far. But if you do smoke, it's not too late to quit. You can still realize the health benefits of that. Even within a few weeks of quitting smoking, your cardiovascular risk is going to diminish. These are some of my favorite graphs ever, very colorful. I'll explain them to you. Limit alcohol is the bottom line here. These graphs are women, and I'll show you some that are fairly similar for men. And let me orient you to these graphs. So this data was published in 2018 in the Lancet, which is the UK's leading medical journal. It was published. It was a massive. There's a massive epidemiologic study that was done by a consortium of academic centers from around the world, funded by the Bill and Melinda Gates Foundation. The graphs are a little bit hard to, let me try to orient you to them and let me know if you don't understand what I'm saying here. But you'll see a 0 here, and this is sort of essentially a neutral zone. And everything above the neutral zone, and so you'll see sort of a multicolored area that's above sort of this median neutral line here, is essentially excess death attributable to alcohol, and everything below this line here is deaths prevented by alcohol. So what does this mean? Well, I think we've known for a long time, and you've probably heard correctly, actually, that alcohol is associated with a lower risk of having a heart attack. That is accurate. That's been known for a number of decades. And I think doctors who also enjoy wine have been happy to promote that in their own biased way, human beings that we are. And you can see, I'll orient you to this line a little bit further, bearing that in mind. So you can see that if you look at the bottom, and it's tiny, but I'll send you the slides and you can look through them yourself if you'd like to get a better sense of it. The dark purple, if we look in, and sorry to orient you to the upper left here, is the world as a whole. So you can see the total volume of essentially years lost to alcohol above the line exceeds the volume of benefit from alcohol, so to speak, below the line. The high SDI is essentially where we live. So this is essentially people with nations with sort of a high socioeconomic level. The upsides and downsides of alcohol are sort of different depending on whether you're in a higher or lower socioeconomic country. But we're in the high SDI here. The purple you can see is ischemic heart disease, which is just a fancy way of saying heart attacks prevented. So you can see in women here, it does certainly prevent heart attacks, but unfortunately, it's way outweighed by most of these colors are different shades of, cancer. And, not just, of course, things that one might think of like liver cancer, but you'll see, for example, this bright red box here is breast cancer, because alcohol does certainly increase a woman's risk of dying from breast cancer. If we go to the next slide here, it's sort of the same story with men. So you see a lot of disease burden above the line here, showing the net negative effect of alcohol, and some prevention of heart attacks here below the line. Again, that's accurate, but it's just showing that it's fortunately pretty heavily outweighed by the negatives of alcohol. And the conclusion of this study was that there is no level of alcohol consumption that is healthful, that actually promotes health. Now, does that mean that somebody who has a small amount of alcohol is on a fast track to the grave? No, that's probably not true for the average person. But I think it's important to dispel the notion that it's something that's healthful. And I think this study was really a groundbreaking study that really demonstrated that medicine had, sort of not quite fully understood it for a long time. I mean, of course, we've known for a long time that, there's all sorts of negatives, and, cirrhosis of the liver, and, I could go on and on. But in fact, I think this really illustrated fairly starkly what a net negative it actually is. Control your blood pressure. A hugely important thing. And what does that mean? This data here is from probably the most important blood pressure trial ever published. This was published in 2015 in our flagship journal, the New England Journal of Medicine. This trial looked at about 10,000 people. This was a multi-center trial. I think it was entirely done in the US. They enrolled people with a known history of high blood pressure. And to get into the trial, you were eligible if you were age 75 or older. And I think probably everybody, unless there was a junior super genius who skipped several years in elementary school and junior high to get into the San Rafael class of 1960, everybody on this call would have been eligible for this trial simply by being age 75 or older. Or if you had chronic kidney disease or cardiovascular disease, and you were younger, I think you had to be at least age 50 and have one of those, then you could have gotten into this trial. And what this trial tried to look at was, we've known for a very long time that if you look at population-wide studies, that cardiovascular risk, your risk of having a stroke or heart attack, starts to increase when your systolic blood pressure, which is your top blood pressure number, is in the upper one teens. However, for a long time, a very long time, we defined high blood pressure as a systolic blood pressure greater than 140 or greater than 90 diastolic, greater than 140 over greater than 90. That's what it was for a very long time. And we called 130 to 140 sort of a gray zone, borderline. 80 to 90 on the diastolic was a gray zone, kind of borderline. So this study looked at a very important question that no one had answered. We used to treat people to a blood pressure goal of less than 140 over less than 90. Sometimes people with higher risk, somebody with diabetes or heart disease or that, we might treat more aggressively. But the average person with high blood pressure, the idea was to get them less than 140 over 90. This trial asked the question, what if we normalize blood pressure? What if rather than going for less than 140 over less than 90, we took people to 120 over 80 or below? It was a pretty radical idea. People were afraid that wow, are you going to start compromising people's quality of life with the drugs it's going to take to do that? Are people going to fall? Are they going to feel bad? You know, like, is this a bad idea? You're doing that with all these people in their, you know, in their 80s. Like, are you crazy? But the trial went ahead, and you can see they enrolled about 10,000 people. It's a gigantic trial, and people got randomized to an intensive treatment group with a goal of systolic 120/80 versus usual care. And the trial was stopped prematurely by the Data Monitoring Safety Board. Any significant trial is going to have investigators who are not involved in any way in the trial, who monitor the data. And if there's a significant trend, if something becomes statistically significant, such that essentially the question's been answered, and particularly if patient safety, if we need to know for patient safety reason, they will, you know, essentially raise a red flag and stop the trial. And this trial was halted early by the Data Safety Board, and it essentially got leaked. And there were 2 articles in the New York Times on the front page before the New England Journal could review the data and publish it in the fastest turnaround time they've ever published anything, which was about 8 weeks. Because if it shows up in the New England Journal, you know, it's like it came from God. And so all of medicine is going to look at these articles, and they want to be very, very, very careful with anything that's published in God's medical journal. So, and this is what they found. So you can see the blue line here is the standard medical treatment. So this was achieving the standard of care of the day. You can see systolic blood pressure here on the vertical axis here, the y-axis, and you'll see that they ran them in the mid-130s. So they achieved the standard of care of that time in 2015, which is, you know, so 7 years ago now. And here's the intensive treatment group. They got them down to an average systolic blood pressure of 121, which is frankly incredible that they were able to do this. But a lot of people worked very hard on this. And why did it matter? Well, here's what happened. So at the top, you can see on the blue line is the standard treatment group, and the likelihood of having an event in a composite endpoint, which I'll explain in a moment. And here's the intensive treatment group, which you can see was 25% less likely to have this event. The composite endpoint that they had was heart attack, or essentially a heart attack type syndrome, something called acute coronary syndrome, a stroke, heart failure, or death from cardiovascular cause. And you can see, so 25% reduction in that composite endpoint. Essentially, the composite of those bad things was 25% less likely to happen in the people who were treated to a systolic blood pressure of about 120. And the big surprise was this down here, death from any cause. I think that's pretty self-explanatory. And the people in the intensive treatment group, remember, this was a randomized trial. This is a randomized controlled trial. People in the intensive treatment group were 27% less likely to die, period, end of story. And you can see the mortality curve splitting here at 2 years of treatment, 2 years of treatment. So what this means is that if you treated, all you need to do is treat 90 people more aggressively, that is target of 120 versus the mid 130s in their systolic blood pressure, and you will save 1 life. That is a very powerful intervention and a major change. It caused the blood pressure treatment guidelines to be rewritten. This radically changed medicine, this study. Although there were a few more falls, there were no more injurious falls in the intensive treatment group. And there's been plenty of sub-studies. There was no difference in quality of life. People did fine. Now, does that mean that every single person over the age of 75 should have their blood pressure run with a systolic of 120 as their target? Well, no, probably not every single person. But it's definitely worth a conversation, your own physician, because this is a very powerful intervention, and it certainly changed our guidelines, which now suggests achieving a target of less than 130. But it's good to know that in the trial, they got it even better than that. So control cholesterol aggressively. That's another important one. And here's, this is from a review article published in the New England Journal of Medicine in October of 2019. And statin drugs they must be the most studied drugs ever in the history of medicine ever. I couldn't even imagine how many thousands of statin trials there have been. And the net is that here you see it in writing, per 39-point reduction in LDL in trials, on average, there's a reduction of about 22% in cardiovascular events and 10% reduction all-cause mortality. That's saying something. And let's look at that a little bit more. And this is a very interesting trial that was published in the New England Journal in 2017, which looked at people with what we call secondary prevention of cardiovascular disease. So these were people who had a history of a heart attack. You needed that or something sort of akin to that to get into the trial. And these are all people who were treated with statin medications. You had to be on a statin to get in the trial. And they used a new sort of very sophisticated injectable drug, an antibody called evolocumab. We know of it as Repatha. It's easier to say the brand name. But this is typically a once-a-month injection antibody that was given in addition to statins. And they looked at people with an LDL, or the quote bad cholesterol, that were running about 90 at that time. And they compared it with a group that they ran at about 30 when this particular drug was added to statins. And what happened? You can see here that essentially there was a 15% reduction in a primary endpoint, which was also a composite endpoint: cardiovascular death, heart attack, stroke, hospitalization for unstable angina, which is sort of like a heart attack that may or may not sort of complete, so to speak, or coronary revascularization. And the secondary endpoint also achieved statistical significance, a 20% reduction in the composite of cardiovascular death, heart attack, or stroke. Certainly that got proven with this particular drug combination. Repatha is not a cheap drug. Statins are very cheap drugs. But essentially no one has ever shown that there's such a thing as an LDL, a quote bad cholesterol, that is too low. And this trial demonstrated, benefit from fairly radically low levels, LDLs of 30. Cancer screening is, the benefit of cancer screening is probably very limited at the age of 79, as you saw from the initial data. In general, when we think about cancer screening, we think about, the likelihood that someone's going to benefit from it is probably pretty limited if there's not at least a 10-year life expectancy, as you saw from just the data there. Some people will certainly live more than 10 years. Many people that's sort of bumping up against at least the statistical life expectancy, but everybody's an individual. It's very case by case. And in general, there's not a sort of a hard, so to speak, cancer screening recommendation at the age of 79. That said, it's very case by case, and cervical cancer, essentially every national guideline says stop at the age of 65. Probably very little value of that at the age of 79. Colon, breast, prostate, the value is probably fairly limited at any age, even less so at the age of 79, although there is a demonstrable value. Skin cancer, I think, has the upside of being pretty easy to screen for. It's pretty easy to have a dermatologist look you over head to toe, or ask your regular doctor to do that, and frankly, keep an eye on yourself and point anything out to anyone that is concerning to you. Very case by case. I think, I think about in my own patients, we'll continue some of this, but it's sort of very individualized, and the impact is nowhere near as close as blood pressure, lipids, exercise. Fall prevention, as you saw, accidental death, falls are included in that. It's pretty common, and it becomes a bigger problem the older people get. And there's actually a lot that can be done to prevent a fall. Exercise has in a range of forms, and there's been tons of trials done, whether it's aerobic exercise, whether it's sort of kind of gait and balance training, physical therapy, whether it's general strength training, whether it's movement type stuff, Tai Chi or dance. There's data to support all of that. People who do this type of stuff, keep their muscles toned and strong, are simply less likely to fall. Medications, first do no harm. We docs end up accidentally doing a lot of harm. And so always good to review your med list. I think certainly on an annual basis with your doctor, think if there's any drugs that you want to be, are they earning their keep? And some of them certainly can increase your risk of a fall or cognitive dysfunction or that type of thing. So something important to bear in mind. Vision, very important, preventing falls, treating cataracts, having a lens replacement, not seeing something very well, it's much easier to trip over it. Thinking about modifying your home environment. Clear the walkways in your home. Don't leave that vacuum cleaner in the middle of the floor. Nighttime lighting. There's a trip to the restroom at 1 a.m. is a dangerous trip. Try to keep it as safe as you can. Make sure you have adequate nighttime lighting. Shower and bathroom safety. Grab bars. Shower seat. All this type of stuff is very non-slip pads on the in the shower, on the bathroom floor, that slippery tile. People wipe out, fracture their hips. It's just, the ERs of America are full of this at 1 a.m. The good news is there's a lot you can do to help keep yourself out of that ER at 1 a.m. Postural decreases in blood pressure. As people get older, frankly, if any of us leap up fast enough, gravity is going to push down and our arterial pressure is going to have to push against it. We can get a little lightheaded. Everybody's experienced that. If you're dehydrated, you'll notice it a little more. As people get older, the part of the nervous system that you don't have to control, it automatically gives your arteries a little squeeze to keep blood going back up towards your brain as you stand up or get up out of bed. Doesn't work as well. And so you're going to experience a drop in blood pressure that may make it more likely that you fall or transiently lose consciousness and fall and have an injury. Take your time getting up. Don't go flying up out of bed at night in particular. Use assistive devices if you need it, a cane or a walker. If you're having foot pains or problems, think about your shoes. There's some data to support normal vitamin D levels as being associated with a lower risk of having a fall. Cognitive protection. Exercise is probably, the data for all of this is not great, but there's a lot of associations. Exercise is associated with a lower risk of cognitive decline. That's probably the most significant thing on this list right here. a lot of it's soft data, but social interaction, what you're doing right now, reconnecting with your friends from high school, other friends, people, family in your lives, that can be very important. There are cognitive training exercises. People do crossword puzzles, Sudoku, various things. Again, a lot of this is kind of weak evidence, but certainly probably not a great downside. Education is associated with what's known as cognitive reserve. The greater education someone has, it seems like essentially the more they have to protect them against cognitive decline, that they're likely to fall back on in terms of compensation. Correct thyroid dysfunction or vitamin B12 deficiency. That's something that your doc can survey you for. Treat mental health disorders. Certainly depression is associated with memory loss, and treating really common mood disorders become even more common as people age, and they're very undertreated, but they're actually often they're not super hard to treat. Medicine's actually pretty good at treating them with meds, therapy, or both. Can be cognitively protective. Treating high blood pressure. Alzheimer's disease is the #1 cause of dementia in the United States or the world. But cerebrovascular disease of the small vessels in the brain or even the larger arteries in the head and neck is the #2 cause, and a lot of people have a little bit of both. It's been shown that treating high blood pressure does reduce the risk for cognitive decline. And a Mediterranean diet has been shown to be good for just about everything, and it may be cognitively protective. So, it's about 3:45, and that's the end of my slides. And maybe you have some questions.
Wow, I feel like I need to go and take a walk right now. One of the questions, Ron, that we were posed with prior to your presentation was about when should we worry that memory losses are more serious than just being forgetful?
Yeah, I think that's a really good question. In general, it's memory loss that's associated with, impairment in functionality. Inability to sort of manage numbers, finances, inability to manage things, sort of safely around the house, leaving the stove on, certainly would be, alarming, forgetting how to, button a button, that type of thing, getting lost in a familiar neighborhood. It's pretty common as people get older to have trouble coming up with someone's name. And that in and of itself is not necessarily evidence of a significant cognitive disorder, particularly if it's something that, like an hour later, you're like, oh, that's right, it's so-and-so. So that's sort of like delayed, recall. But, when people, start getting beyond that, I think it's a good idea to go talk to your doctor. And as you saw in that list that I have, there's, stuff that, you can think about. And frankly, so thinking about, is a med that you're on, for example, potentially creating a problem. I think it's always good. The older a person gets, the harder the meds should work to deserve their spot on your medication list.
Great. Okay. And what are your thoughts on supplements?
In general, there's not very much evidence to support supplements of any sort. I think the one to focus on is probably vitamin D. Vitamin D deficiency is extremely common, and it's easy to replace. That vitamin D supplementation may help preserve bone density or help preserve a decline in bone density. And it may also help with muscle strength. It may reduce the risk of a fall. I don't think that's been well proven, but it can be, it can be supplemented. Super doses of vitamin D or anything are inadvised. But you can, although guidelines would suggest like you don't need to check your vitamin D level, it's frankly super cheap and easy to do so. I check it in my patients, I check it myself, and I'm on 2,000 units a day because, you know, my vitamin D level is in the mid 20s, like a lot of people who spend a lot of time indoors at a desk. Yeah, better to replace it with a supplement than go bake yourself in the sun.
A lot less fun, but yes,
Yeah, it could be
understandable.
true. Yeah.
How important would it be for someone of our age group to get a full body scan?
Wow. What a great question.
Wasn't mine, somebody submitted it.
Yeah. So my advice would be run the other way.
But, okay.
I'll explain. You know, our ability to generate massive amounts of data is just getting easier and easier. And you're right, you can go out and you can, I don't know exactly what it is. It's not a massive amount of money to get a scan from stem to stern and an MRI and this, that, and the other. But there's a difference between sort of data and sort of, you know, knowledge. And so the problem with that is that, look, you're going to find something. And, you know, are you going to find anything actionable? No one has ever proven, first of all, that reduces morbidity or mortality. And you've already heard me say, like, gee, something that's proven in younger people, like breast or colon cancer screening, you know, maybe at age 80. You know, I'll do it in a number of my patients who are doing pretty well at age 80. But the older you get, the less like you are to help somebody with that, and the more like you are to harm somebody with that.
Okay.
So it's not hard to imagine a situation where there's a little ditzel and someone wants to go after it because medicine's very conservative, and you end up biopsying it, and, you know, who knows what complication comes from that. And you can end up, our sort of colloquial term in medicine for this is you can end up on a fishing expedition. And suddenly everybody turns around and wonders, how'd we get here? Like, what are we doing? Like, how'd we get here? And so I think, you know, it becomes a risk benefit type thing. So the benefit's unproven. It's not difficult to imagine the harm that could come from it in terms of things that people might want to do to you, or the stress that it might create. Are you now not sleeping at 2 a.m. because you have this, you know, I don't know, 7 centimeter thing in your 7 millimeter thing in your pancreas that someone wants to take a picture of every year and you're age 80. You know, I mean, it's just, you know, and now it becomes a thing. So that's why I'm not in favor of that.
Well, we had several of these questions that were presented to us ahead of time,
Yeah.
which I think kind of helped with the flow of the presentation. But is there anyone who has another question that they would like to present to Dr. Ron that he can answer for us?
Barbara? Yeah,
No.
this is Lauren. Dr. Ron, I was impressed by the difference when we were talking about blood pressure.
Yeah.
Between the standard treatment and the intensive treatment was an enormous difference. What was the actual difference in the treatment that created that outcome?
The difference was they used more blood pressure medicine, basically. They didn't use any, you know, doctors had the same, you know, choice of blood pressure. You know, they didn't tell you what blood pressure medicine to use. They just set a lower target.
I see.
So, so people just got more drugs. There's a number of, you know, the most common drug classes have mortality data supporting them, and you know, a lot of safety data. Of course, it needs to be monitored and that. But yeah, people used you know, the same drugs. They just used more of it.
How safe is that?
Well, it reduced people's risk of dying by 27%. So I would say in net, that's pretty safe.
Okay.
More likely to live. But I think to circle back though, right, there was the question of like, okay, like did people live, but they felt terrible, they felt like drugged out, they felt lightheaded all the time, like who'd want to live that way, or they're falling down all the time, that type of thing. And it was determined that actually didn't happen. People were more likely to have a fall on that. And so of course you have to use good sense, and people, backed off the blood pressure treatment on those individuals. Remember that systolic that they got to a target of 120, they achieved 121 average in that trial was, that's the average. There were some people who were in the 1-teens and some, they were in the intensive treatment group. Some of their doctors probably let them ride up a little higher because, they were getting too lightheaded when it was down that much. But on average, this is what's called an intention to treat analysis, which means that the people at the start, like here we go, we started here, and the trial starts running for a few years. It was what group you were in at the start, not like crossover or whatever happened. It's the most rigorous analysis, intention to treat. How did you get originally randomized? It makes it much harder for people to sort of play games with the data. So it's randomized intention to treat analysis. And so, yeah, that's why the blood pressure guidelines got rewritten.
Okay.
I've
So
got a
shall we
question.
turn this back over to Lorne to have him kind of wrap it up for us?
I've got a question.
Oh, another question?
Right.
Yeah. Who's the best person you mentioned to, review the meds you're taking? Who's the best person to do that? Is that a pharmacist, a physician, a GP, a primary care doc? Who's going to tell me what meds I don't need to take anymore?
That's a really, really good question. I think the person who's best positioned to answer that for you is probably your regular primary care doctor. Is going to be the best person. And a simple question you could ask is just like, can we just review my medicine list, and can you remind me why I'm on each of these medicines? I just want to understand it. And are there any of them that I should think about stopping? And, sometimes, people end up on drugs, and docs are in a hurry, days are busy, and drugs just ride. It's like, your medalist, and like people in a hurry, and, so I think that's a great question to ask, is just ask it that way. And let people talk it through. They may think that like, oh, you're on this because I thought you were having back pain. I left you on it. No, I don't have back pain anymore. I'm doing fine. I'm like, I started the exercise. Oh, okay. Well, maybe we can throw that one overboard. So, so I think that's probably the best person to answer it. That's a great question.
I have a question. You talked about cholesterol and the LDL, but what about the good cholesterol? Is there any indication that you should be taking fish oil supplements or something like that to get good cholesterol?
That's a really great question. The interesting thing is that the more we've learned about good cholesterol, the more it appears to be sort of more of a passive marker of it fits certain cardiovascular patterns, but no one has ever shown that any intervention to try to actively boost it has ever improved an outcome. So, and don't think that people haven't tried. There was, in the early 2000s, I've been practicing medicine for amazingly more than 20 years now. I finished my residency in 2001. In the early 2000s, if somebody had a heart attack, they'd end up on a statin. We put them on a drug called niacin, and people get flushed and sweaty on it. And it would raise their HDL in a lot of people, and it would lower their LDL a little bit, and it would also reduce their triglycerides. It seemed like the perfect drug. No one had ever done a randomized study of it, but people just assumed because that pattern looked okay that that's what we wanted. And then finally, a randomized trial was done in maybe 2005 or 6, and we realized that it was of no benefit. In fact, it was net harm, and it got basically, largely tossed out of use. Pfizer had a drug that was fantastic at raising HDL. They were boosting people's HDL up to their 80s, but it got shut down in a phase 2 trial because mortality was higher. So people were dying with a high HDL, but we were a little more worried about the mortality endpoint there. So it's a great question, and the answer is these days it's all about destroying LDL. The single best marker that's on all of the drugs that cause plaque is something called ApoB. It's a marker that's on LDL particles and it's on other atherogenic particles. LDL has been the focus for a long time. I won't bore you with the details of why that is. And ApoB certainly tracks with LDL, but triglycerides also have particles that contain triglycerides have ApoB on it. If you wanted to be really tricky, you would you could destroy your LDL, which would bring your ApoB down. But if you wanted to, an ApoB test these days is very cheap. It's probably $15. You could ask your doctor, like, "Hey, what's my ApoB? Have I knocked the hell out of that one too?" How would they do it? Well, they'd use the same drugs typically. It'd be like, raising your statin dose, or there's other stuff one can think about, but it's less focus on HDL these days.
Uh-huh.
Any other questions from the group? Well, maybe we will end it here then. Dr. Ron, this has been very informative, very worthwhile, and certainly subject matter that we can all relate to. So we thank you for your time in putting this together, and Phil for arranging.
You're welcome. Yeah,
It's been great to have you with us, and thanks for all you're doing. We appreciate
happy
it.
to do. Well, from age 51, I hope to make it to your seats in 28 years.
Thank you again. And Barbara, thanks to you, and thanks for everybody for attending. We'll see you in 3 months.
Take care now.
Thanks.
Thank you. Happy New Year.
Thanks to the committee.